Hi, my name is Natalie Whitkin. I work for Willow Breast and Hereditary Cancer Support, and I oversee the Broad Day activities in Canada. And I'm going to come out and talk to you a little bit later after the presentations, but I want to introduce our first plastic surgeon and speaker, Dr. Toni Zhong. She's at University Health Network, and she's going to talk to you about reconstruction using implants. Dr. Zhong is a plastic surgeon and the clinical and research director of the breast reconstruction program at University Health Network. In case being a doctor and a plastic surgeon wasn't enough to keep her busy, Dr. Zhong also has a master's degree in public health from Harvard University. She is a scientific spokesperson for the Canadian Breast Cancer Foundation and the provincial lead for developing clinical guidelines in breast reconstruction for Cancer Care Ontario. So she's well equipped to be your first speaker tonight. We're very excited to have her. How it's going to work is Dr. Zhong is going to talk about the basics of implant reconstruction. Then she's going to present a sort of a patient's case, and then her patient, Jeannie, is actually here, and she's going to talk about how she made the decision to have surgery and her experience. So we're very excited to have this presentation tonight. May I please welcome Dr. Zhong.
Thank you, Natalie. What a turnout. This is great. Thanks to everyone who's coming out to support Broad Day. And I'm here to talk to you about implant reconstruction. So implant reconstruction is important because it is the single fastest growing technique for breast reconstruction across North America. In fact, in this study that we did right here in Ontario, we found out that in the last decade, using implants to reconstruct the breast after mastectomy increased 100%, while other methods of using the patient's own tissue to reconstruct the breast stayed relatively constant. So why this increase in implant reconstruction? Well, this paradigm shift was set into motion long before this much publicized surgery that Angelina Jolie underwent. In fact, this paradigm shift was put into motion probably as a result of all four of these factors that I'm going to talk about briefly here. First of all, women's attitudes towards breast reconstruction are changing. My patients tell me, I had reconstruction not out of vanity. It's just a matter of being able to wear what I want to wear and feel comfortable with what I'm wearing. I could never wear a swimsuit or that sort of thing. Most of my clothing was just off limits, even with the padding, because bras, well, it just doesn't look right. So you can see from these direct quotes from patients that breast reconstruction does serve a functional and pragmatic purpose. Not only are the attitudes of women changing, but so are the opinions of breast reconstruction surgeons performing this type of surgery. This study surveyed female plastic surgeons performing breast reconstruction on their preference in choosing between different reconstruction methods. And 66% of the plastic surgeons chose implant reconstruction as their #1 choice. And they cite faster recovery and relatively non-invasiveness of the procedure. Secondly, patients who are undergoing mastectomy today are younger. First of all, this is probably attributed to genetic testing being more widely available and the effectiveness of prophylactic mastectomy with reconstruction. But also, unfortunately, it is because breast cancer is being diagnosed in younger women today than a decade ago. The third driving force behind the increase in implant reconstruction is that now we have safer as well as a wider selection of breast implants. In the United States, the Food Drug Administration, or FDA, requires regulatory surveillance of silicone implants, and this has helped to alleviate some of the concerns around the safety of implants. Lastly, we now have improved surgical techniques in implant reconstruction, and this has helped to make our reconstruction outcomes more natural looking and more aesthetic looking. So out are the days of this sort of very deforming radical mastectomies, and today our surgeons tend to perform more structural sparing, like skin-sparing mastectomy with immediate reconstruction, or even at times nipple-sparing mastectomy with reconstruction. So now to the more technical aspect of my talk. When I'm assessing my patients in my clinic for implant reconstruction, what are the thoughts that are going through my mind? Well, I'm thinking and determining whether my patient needs a unilateral or a bilateral reconstruction. What is my patient's body habitus, or what is her body build? And lastly, what does my patient expect for her reconstruction result in terms of her shape and volume? And is this a realistic expectation and in keeping with her own breast shape and volume? So when I'm assessing my patient for unilateral reconstruction, our goal is to match the reconstructed breast to the opposite breast. So in the case of this woman who has right invasive breast cancer, who needs to undergo right mastectomy and wishes to undergo immediate reconstruction using an implant, because she has anatomically shaped breasts, or her breast shape resembles more of a mature woman's shape, following her right skin-sparing mastectomy, we immediately reconstructed her with tissue expander and exchanged her for anatomically shaped cohesive gel implant. And this is her after her surgery and after she had nipple areolar reconstruction. This patient, on the other hand, has a rounder and more fuller appearance for her breast. She actually has left DCIS and has elected to undergo mastectomy with reconstruction. So this is her after undergoing skin-sparing mastectomy on her left side, and we reconstructed her with a extra projecting smooth round silicone implant and reconstructed her nipple areolar complex. So in patients who are going to undergo bilateral reconstruction, our goal is to work with the patient and try to achieve their desired final volume and shape for breasts. So in the case of this woman who has relatively anatomically shaped breasts, we elected to perform her bilateral mastectomy and reconstructed her with anatomically shaped silicone implants. And in this young woman who had to undergo bilateral mastectomies, but she wanted to be fuller and bigger after surgery, so we reconstructed her with extra projecting smooth round silicone implants. The second thing that I really take into consideration is a patient's own body habitus or body build. So in a patient who is relatively thin or normal weight, generally speaking, we can achieve their desired or preferred breast shape and volume, whether it's anatomic or round. But in patients who are heavier and have large breasts, generally speaking, we're limited to using extra projecting round implants in order to obtain that maximum volume. But I do warn my large-breasted women that sometimes they can be disappointed with the result because large implants generally don't feel as natural and can feel heavy. So lastly, and I think perhaps most importantly, is that I need to know my patient's expectations from her implant reconstruction. Most commonly, I will say that my patients just want to be as close to what they had before surgery. But there's always a subset of patients who want to be bigger and perkier after their mastectomy and implant reconstruction, and that's generally achievable within reason, especially when combined with newer techniques of skin-sparing mastectomy or nipple-sparing mastectomy. And then I have a third group of patients who are relatively large-breasted, who have ptosis or more breast droop, who wish to be smaller and lifted. And we can generally achieve that using a larger incision and using breast implants to give their breast shape some lift. However, one thing that I do warn my patients of is that no matter what we can achieve or accomplish at the time of surgery, one thing that is out of our control is how the implants will change over time. So bottom line, to wrap up, is implant reconstruction the next best thing? No. Is implant reconstruction the right procedure for everyone? No. However, my patients who have undergone implant reconstruction or using their own tissue tell me that the benefits of reconstruction, both emotional and physical, can be life-changing. Thank you for your attention. So I'm gonna move on to the next part, and this is the most interesting part and the part of the evening that I've been looking forward to the most. I'm gonna introduce you to who you see on the screen, and we'll just call her Mrs. JD or Jeannie. So when Natalie from Willow asked me to bring on the stage a patient of mine who has undergone implant reconstruction, who I felt could talk to the audience about her personal experience in a way that the audience can relate to, Jeannie immediately popped into my mind. So what I will do just very briefly is just tell you her clinical history. But I think what's most important and compelling is Jeannie's personal account of her breast reconstruction journey. So I met Jeannie back in October 2009. That was my first meeting with her, and she was considering undergoing bilateral delayed breast reconstruction. Well, after the initial meeting, I met with her twice more before we finalized her method for reconstruction. Then in February of 2010, she underwent surgery for bilateral insertion of tissue expanders. Between February to May, she had a series of tissue expansions in the clinic. October 2010, she had another surgery where we took out the tissue expanders and put in round, smooth implants. She healed relatively well. I don't think there were any post-operative complications. She did waste some time before she was ready to have her nipple areola made. And she saw me that one time we made her nipple areola, and I think I didn't see her again after, at least not in the clinical setting. So without further ado, I'd like to bring on Jeannie to the stage so she can talk to you.
Thank you. Hi, I'm Jeannie Davis, and I've been asked to tell you my experience as an older woman who had bilateral mastectomy and reconstructive surgery. I imagine you probably have lots of questions, and I thought that I could answer them by asking myself three major ones. Number one, what made me decide to have the reconstruction, and what method did I choose? But now you've really heard all that from Dr. Zhong. How did the procedure work, and how did I go through it? And number three, how has having the surgery changed or helped my life? Anyhow, when I first heard about my diagnosis and treatment, I immediately asked if I could have reconstruction. And I was told that it wasn't appropriate at the time of my mastectomy. So I accepted this, but as soon as possible after the surgery, I went to Elmira to be fitted for bras and prosthesis. I bought daily ones, and I bought waterproof ones, and a bathing suit with pockets for the waterproof ones, and I decided this is how I was going to be, and I made peace with it. But when I went to my oncology surgeon for a checkup, he reminded me that I had wanted reconstruction, and he gave me a referral. It took a while to get the appointment, and by the time I got it, I wasn't even sure I was going to keep it because I was 75 years old, and it seemed like the epitome of vanity to equip myself with new breasts. But we do a lot for pure vanity. We get waxed and plucked and pierced. We do our makeup and our nails, and we try to dress nicely. So I gave it a lot of thought. I had become kind of self-conscious with the prosthesis. I thought that I could freely go without a bra and just wear a t-shirt, but I found I was carrying my purse over my chest. I became more modest in dressing rooms and locker rooms, and I realized that anybody taller than I was could look down my bathing suit and see my flat chest and scars. So I decided to go to the appointment and see what my options were. And as Dr. Zhong said, I actually had 3 appointments. At the first meeting, I learned I was a candidate for either the implants or using my own tissue. And both procedures were explained very carefully, and I went home to consider which one I would choose. I wanted to use my own tissue, and at the second meeting, Dr. Zhong examined me and explained that I had very little belly fat, and she would only be able to make 2 smallish breasts. And it was a very, very long surgery. And my children felt at my age a long surgery was not the best idea. They also were very supportive, so I felt I had to agree with them. The implant method involves shorter surgeries, but there are 2 of them, and a series of what I always call the tuning up appointments. At the 3rd meeting, I told Dr. Zhong that I decided on the implants, and we set a date for my surgery. She was always patient with me and wanted me to be sure I knew what I was doing. As a matter of fact, when I saw her here tonight, I gave her a big hug, so you have to know it was a successful pairing up. Okay, question 2, how was the procedure and how did I get through it? So the first stage of implant surgery is to have I think they're called tissue expanders, I just call them forms, inserted under the muscles of your chest. I stayed overnight in the hospital because I always become nauseated from the anesthesia, even if they put an anti-nausea drug in it. It always gives me a lot of anxiety, actually. The pain was moderate from the surgery, and it was alleviated with Tylenol 3. It felt more like tightness and pressure than actual pain. I had drains, but I also had the beginnings of little breasts. Even under the bandages, I could see the little bulging, and it was very pleasant to see. I had to have someone stay with me overnight because I have a lot of stairs in my house and I live alone. I was able to be up, but I was tired and achy, and actually I had someone stay with me for about 4 days. And a nurse came daily to empty the drains and to give me a checkup. The drains were removed on day 5, and I was able to be up most of the day. My biggest problem with surgery and general anesthetic is always my digestive system, and I think the worst pain is always gas pains. The surgery is never as bad as the gas pains. The tune-ups started, I think, about 3 weeks after the surgery, and this is where they insert a saline solution into little valves in your tissue expanders, and the amount is increased in each session until you get to your desired size. And Dr. Zhong kept saying to me, keep trying on your clothes at home and don't get too big. I think you can be either large or small. I sort of wanted to be the same size I was before surgery. It was about 2 weeks between each session. They were fairly flexible. They're totally painless, and I used to walk to and from the hospital, so you can tell it was not a big thing. I had the final surgery about 6 months later, and it was easier than the first in that the pain was mainly the soreness around the stitches around the drains. I had somebody with me for 2 nights that time only. And after the surgery, I went to the clinic to have the nipple and areola, the areola tattooed and the nipple built. I had to have a little freezing because I still have some sensation in my breast, which I understand a lot of people do not. The answer to my last question is easy. I was never sorry with my decision. And actually, I had told a friend that I was doing this, and she was getting a new knee, and she said, oh, I'd so much rather be getting new breasts. So, thank you. I think I'll just say thank you and good night.
So I think it took a great deal of courage, and because I know Jeannie, she's very modest, so for her to come up here with me.
I'm not going to take off.
So I just really want to say just such a heartfelt thank you for being out here. I know it wasn't easy for you.
No, we'll do that. Thank you.